So after Rachel's very interesting talk on pelvic floor, I will continue to talk about the urinary continence part, which is what most people would find bothersome. So so often we actually, you either hear someone or even yourself or your friends that, hey, over the past few months, I actually need to pee more often, and sometimes it is so urgent that, I do have drips and draps coming out. And for other people, they will say that, last time I used to be able to hold for 4 to 6 hours, and now over time, I actually need to go more and more frequent, and sometimes it's even every 30 minutes. And every time when I go, actually, there's not very much coming out. So, and for some others, they say that, when I cough, sneeze, or exercise, or even when I climb stairs, or when I'm cooking, suddenly the urine just actually comes out. So, what is all this about? So, when we talk about urinary incontinence, there are actually several different types. So, as the name implies, incontinence means that there's actually an involuntary loss of urine, or basically there's an unwanted loss of urine that is not within your control. So, there are a few different types. So, urge means that, you feel that, I really, really have to go, and sometimes it's usually comes with the frequent feeling that after you go, you always need to go again, and usually it's within a few hours. All right, and sometimes there's also leakage of urine. So for stress urinary incontinence, I think Rachel did touch on this before. So it means that with any additional pressure on the tummy, so things like, you go to the gym, you lift some weights, you go to the market when you carry your heavy sack of rice, or sometimes simple things like, when you do your brisk walking, climbing stairs, you do notice that, and when you sneeze or cough, there is some urine leakage coming out. So for mixed incontinence, it's actually a combination of the first two. And actually, the common reasons for this are, yes, there could be pelvic floor issues, but sometimes it's also linked to underlying medical issues, or especially for women and men, post-surgery or post-childbirth. So I'll touch on this more later on. And for some people, especially if you notice in your older relatives, sometimes they may say that, sometimes basically I don't ever feel the urge to pass urine, maybe only once or twice a day, and sometimes it just overflows out. So overflow incontinence is something special in the sense that it's usually due to patients, for example, with poorly controlled diabetes, or they have underlying neurological issues where it affects the bladder feeling of fullness. So the bladder gets stretched so much that at some point in time, it's like a pail that is overfilled with water, and that's when it leaks out. So it can also happen in men where they have basically what we call enlarged prostate, which is very common in men aged 40 years and above. Sometimes when there's a blockage of the outflow of the urine from the bladder, it actually can cause overflow. So for functional wise, the functional means that actually the urine leakage occurs because we have difficulty going to the toilet in time. So sometimes this is related to the layout of your house, like if your toilet is quite far from your bedroom, or sometimes you have difficulty getting to the toilet because of walking issues. Okay, so we've actually covered this. So some of the triggers for urge incontinence, sometimes some people may notice that, in a cold place, all right, or even caffeine intake, all right, or even the sound of running water can actually make them feel like they want to pass urine, all right. So go on to the next slide. I've covered this. So the treatment, or how we can manage overflow incontinence, I think the first thing is that we need to assess why are we having this. Is it because the bladder's feeling is basically not as good as before? And of course, or in some people, in men, it may be due to enlarged prostate, so we will treat that accordingly. So sometimes, with the bladder is overstretched, and they cannot feel when it's full, what happens is that we can do things like time voiding. That means within a few hours, every 3 to 4 hours, you will tell yourself, okay, I need to go to the bathroom to empty my bladder before it becomes too full. And of course, in some, if they have really trouble emptying at all, we have to teach them how to insert a urine pipe, a very tiny urine pipe every few hours or so to basically replicate their own passing urine function. And of course, there may be other treatment options like sacral neuromodulation, which we will touch that. Yep. So for people who have functional incontinence, common things that will help would be things like the caregiver or will actually remind the person to go to the toilet before it becomes too urgent, so that there's sufficient time to head to the bathroom. And of course, we do have toileting aids, so things like bedpans or even a commode could be actually very helpful. Okay, so the thing is, what actually makes me at risk, or if if your relatives have some urinary incontinence, it may be related to why certain underlying factors. So the most common thing for urgency is actually related to fluid intake. It's good to take adequate amount of fluid, because basically at the end of the day, you need to make sure that you're well hydrated. And one sign of that is if you look at your urine color, it should be a very light yellow or almost colorless. But of course, there are some people who overdo it and they drink like 4 liters a day, even though they are not outdoors exercising in the hot sun. And that can also make you go to the toilet more frequently, right? Because our body actually regulates how much we want to take in versus how much we want to absorb. Okay, so common things will be like, of course, if you drink coffee or even alcohol, these are things that actually stimulate the bladder. And of course, they also do promote your body to produce more urine. So this will definitely make you more at risk of, leaking urine. Aging is one risk factor as our pelvic floor ages, and as well as basically the nerves to the bladder. Actually, sometimes they age with time and they may not be so strong, or they may be not as sensitive as before. So people with previous stroke or Parkinson's disease, all these can affect the control of urination. Diabetes itself is a very big thing, especially if diabetes is not well controlled. What happens is that the sugar levels do affect the nerves, the health of the nerves, and that actually makes the bladder unable to pass urine, or basically the feeling of a fullness is actually much reduced. As well as any previous pelvic surgery, like for the large intestine or prostate, or Okay, so commonly for women and men, the risk factors are slightly different. For women, usually it will be things like, previous childbirth, especially if the childbirth was difficult, as well as a postmenopausal state. So for men, commonly, as Rachel mentioned, the men have 3 doors that actually gate or control the urine. So men usually don't have very much stress urinary incontinence because they do have 3 gates mandating it. But they tend to get that if, say, they have had previous surgery for enlarged prostate, or they have prostate removal for prostate cancer. And of course, men do get urge incontinence also. Okay, so what are the treatment options? I think first thing, it has been shown that, and that's what Rachel had emphasized, if overweight, I think it will be helpful to try some weight loss measures with healthy diet as well as exercise. Smoking has been proven to help, quitting smoking has been proven to help as well. And of course, regulating the types of fluid you are taking as well as the fluid intake. So as Rachel has mentioned, the pelvic floor muscle exercises do help with both the urgency and the leakage associated with stress incontinence. For women who are post-menopause, especially if there's a lot of dryness down there, or as the female hormone drops, basically applying some local estrogen down there can actually help with both the symptoms of urge as well as stress incontinence. And in some, if the leakage is significant, despite all of this, I think the first step is that we do need to make sure that there's some control of the urine leakage, so that it makes it basically acceptable. So there are certain things like absorbent pads, like these, which look like panty liners. For men, sometimes they can use the condom sheaths. And of course, if the leakage is quite significant, some of our men actually do use this penile clamp, but please be careful about using this. So basically, it's a clamp with two cushions, and basically they apply it across the penis to reduce the leakage of urine. This is only for men with quite significant leakage, that it happens almost all the time. But we have to be aware that they should not wear this for more than 3 to 4 hours at any point in time, because it can cause skin problems and erosions at the site, and definitely they cannot keep it on overnight when they are sleeping because of that. Okay, so moving on, yes. So related to pelvic floor exercises, sometimes there's a slightly different thing called bladder training. So bladder training is specifically targeted at the bladder. It's for people who have constant urgency to go and pass urine, but they don't actually have very much passing out. All right, so basically it's a series of exercises conducted over time that basically kind of retrains your brain as well as your bladder itself to tell you that you only need to go and pass urine when you can hold a little bit more. Okay, and this also gives you a fair bit of confidence in controlling back your bladder function, and then which makes it more easy for you to actually engage in your social activities. Okay, so the next step is, okay, if all of that basically has been done, or if your symptoms are quite significant, so sometimes what we can do is that we do start you on some oral medications. So these are quite long names. So basically these are two different classes of drug, anticholinergics, and the other one is called mirabagrant, which is a relatively new drug. So we'll go on with, and of course sometimes it can be combination in both are given. So the idea of combination therapy is that it can be more effective with less side effects, because which I'll talk on in the next slide. Vaginal estrogens can be helpful for postmenopausal women as well. So these are the common anticholinergics that you may have seen. Basically, things like oxybutynin, which is a very old type of medication. And detrusitol sustained release, which is what the SR means. It's actually some of the newer drugs, and of course the newer is called Vesicare or sulfenacin. So all these work on the bladder to reduce the sensation of wanting to pass urine, and it's actually recommended treatments for people with urgency or urge incontinence. So the issue about this group of drugs is that they can cause things like dry mouth, dry eyes, constipation, and we do have to be cautious in people who do have concomitant constipation as well as glaucoma. And there have been some studies that said that we try not to give this long term or in patients where they do already have some degree of cognitive impairment, because it may potentially worsen this. So in terms of the newer drugs, this Betmiga or mirabagrant is actually quite well tolerated. The only significant side effect that it may cause high blood pressure. So usually in people where the high blood pressure is not well controlled, we will not give this. But anecdotally, most of my patients have done very well on this, and they are actually happy to continue this. So the thing is that after the medications, okay, we do know that they do have certain side effects, and actually most people we know, they were like, oh, I don't want to take this medication. Do I have to take this for the rest of my life? Okay, so the answer is that number one, nobody actually knows what is the cause of overactive bladder. It is an unknown cause. So the treatment measures are actually aimed at relieving the symptoms. So for some people, the symptoms do go off after a while, and they can choose to tail down the medications or stop it completely. For some, if they still persist, then we do go on to further treatments. And of course, for those where they find that they don't want to be on medications or they have significant side effects, these are actually quite good options. So there are several options which are quite basically well tolerated because they are minimally invasive. So there are things like percutaneous tibial nerve stimulation, or what we call PTNS. So, and also you've heard of Botox before, right? Botox for wrinkles, so that can be injected in the bladder as well. And of course, the last thing is called sacroneuromodulation, which is SNM. So, okay, and of course, some people may ask, oh, can I go for vaginal laser therapy? Because that's something that might be promoted by your gynae, you know, but the idea is that it's still not very well proven, and there's only a very slight improvement in the symptoms of urgency in the short term. Okay, so PTNS, so for people who go for acupuncture, this is actually somewhat similar. Okay, so what happens is that this nerve, the tibial nerve, actually is a nerve that runs behind your ankle lah. So this nerve actually goes up into the spine, into your backbone, and from there, there are some other nerves that go towards the bladder. So the idea is that the stimulation of the nerve near your ankle actually helps to reduce the sensation of urgency. So interestingly, it's been found that this acupuncture point called San Yin Jiao point in TCM is actually quite near here, and they actually do use it for the treatment of urgency. But of course, during the nerve stimulation, all right, what happens is that we actually use this electric nerve stimulator that is connected to this very tiny needle, which is actually at the size of an acupuncture needle. And then we do this for 30 minutes each time, once a week for 12 sessions. So usually about 60 to 70% of people will find some degree of improvement in the symptoms, but it usually is not a complete resolution. Yeah. So this is usually how it is done. Basically, you come and lie down on a special chair in our clinic, and it's like getting a foot massage kind of a thing lah. But essentially, the sensation is there's actually this nerve stimulator that is placed at the ankle, and you may feel some twitching of the foot lah, and that's actually normal. So this is actually quite well tolerated. The only discomfort is usually due to the needle insertion. Very rarely is there things like bleeding and infection. Yeah. So for people who actually want a more rapid resolution of the symptoms because it's actually bothering them, so we do have the Botox injection. So Botox is actually something that actually causes muscle relaxation. All right, so what happens is that people have found that, if you inject this into the bladder itself, it actually reduces makes the bladder relax, and therefore, you don't need to go to the toilet so frequently. Okay, this is usually done as a day procedure, and of course, usually most patients go home on the same day with no trouble. There's only a very slight risk that some people may be completely unable to pass urine after the procedure because the bladder is so relaxed. But that's actually quite uncommon because before the procedure we'll already have screen through and make sure that you will actually benefit significantly from it. The so-called downside of this is that it's not a permanent solution because the effects do wear off in about 6 to 9 months. So usually you feel the symptoms start coming back, and then that's time for the next dose. But if you think about it reasonably, if you go for this once to twice a year, it's actually not too bad. So how it's done is that there's no cut in the skin. When you're asleep, we put in a very tiny camera, we see the bladder, and we inject the Botox at 30 different sites in the bladder. The idea is to spread it out to get the bladder to relax. The whole procedure is quite fast, takes only about 5 to 10 minutes. Okay, so next we move on to sacroneuromodulation. So the idea of this is similar to the nerve stimulation in a sense that instead of using the acupuncture point style of thing, we actually put in like a small pacemaker that actually controls the nerves to the bladder. All right, so the thing about this is that usually at least 50% of people will find that there is 50% improvement of the symptoms. So how this is done is that these are the nerves to the bladder. So usually there are 2 phases to this. The first one is a test phase where we put a test stimulator at the near the nerves, and then we try it for about 2 weeks. If there's improvement, then we'll put in the permanent pacemaker. And how big is this? It's actually very small. It fits in the palm of your hand. It's only about 7 centimeters long, and it goes underneath the skin of the buttock lah. So it's completely concealed. So this actually can be the settings of this will be controlled based on your symptoms, and most of the time most patients find this actually quite helpful because it's like they are a new person again. But then again, we do know that this is for some people may not like the idea of an implant within them. So therefore, usually we offer this after they have failed the previous therapies. Okay, so we quickly move on to stress urinary incontinence, where usually people leak urine after they strain or cough or sneeze. So the oral medications are actually not really, they do not have any high level evidence to support their effect, because it's usually this medication called duloxetine, which is actually an antidepressant. So most of the time, when people do take it, they do have significant side effects like nausea and vomiting. So for stress urinary incontinence, I think the main thing is before surgery, we do have to do your pelvic floor exercises. All right, pelvic floor exercises do significantly help strengthen the pelvic floor and can reduce significant stress incontinence. So usually after about 3 months, I'm not talking about post-prostate surgery, but usually about after 3 to 6 months of what we call dedicated pelvic floor exercises. If it's still significant, then we will definitely go on to this. So there are different types. So for women, there are things like bulking agents, which are actually like a filler material, which is completely, which is relatively inert. That's actually injected into the urine pipe to actually help the urine pipe to close. Okay, this is generally quite low risk. And then the things like slings, copal suspension, as well as artificial urinary sphincter, which we'll go on later about that. For men, usually they do have, similar wise to female, they do have bulking agents, sling for the males, as well as artificial urinary sphincter. So the bulking agent is essentially a gel that is actually placed in the urine pipe right below the bladder. The idea of this is that it actually helps to restore the so-called the ability of the urine pipe to actually close up so that it actually leaks less urine. This is actually quite well tolerated by people because it's just a small procedure where there's no cut in the skin. So the effects of this actually is not too bad. At least 50% will have a significant reduction in the leakage, but of course the success rate is not as high compared to other things like slings. So for slings, so the idea of why women leak urine is that other than usually is that the pelvic floor is weak. So to provide the support, basically material is put below. It's like a hammock that actually helps to suspend the urine pipe in women. Okay, so there are a few different types. So usually if people leak more, usually we put what we call a TVT, which is a transvaginal tape. So that, and of course, if they leak less, it'll be things like transobturator tape. But the idea of this is the sling actually is within the body. It goes, there are 2 arms to it. It's a mesh material that goes below the urine pipe and comes up here to support it, to help reduce the urinary leakage. All this is actually made from synthetic material. So even though they have very good outcomes, where basically more than 90% of people are actually dry at 10 years, all right, there's always some concerns about the mesh problems, especially where there's a risk of erosion, or sometimes it may cause things like pain or infection. Okay, so for people who do not want the mesh, what we can do is we can actually harvest a small piece of tissue from your tummy, what we call the fascia, and we use it as a sling lah. Because the concept is similar, we actually use your own tissue to do the suspension, and actually this will not come with any problems associated with the sling, and the effects are actually just as good, if not better. Okay, so some people may have gone to see the gynae and they say that, oh, you know, we do copo suspension, but what is copo suspension? So the idea of this, right, copo means the vagina lah. Suspension means you actually lift it up. So the idea of this is that they put some stitch to basically hike up the vagina that's below the bladder itself, or rather the vagina that's below the urine pipe, to provide support. Okay, so this also has actually been proven to be helpful for women. Okay, and of course, those who do leak a lot, there's this thing called artificial urinary sphincter, where essentially it's a prosthesis or a product that is placed inside, where essentially there's a cuff that goes around the urine pipe, and basically at rest, the cuff is actually helps to close the urine pipe. So when you feel the urge to pee, there's this pump that is put in the labia on one side, and then you actually press a small button there, and it actually helps to empty the cuff, and then so that you can pee lah. Okay. So for men, similarly, there's a male sling, which is also made of synthetic material. The idea is that it is placed below the curve of the urine pipe to support it, so that there's less leakage of urine. And of course, for males, the cuff is placed at the urine pipe, which is completely concealed. The pump is placed in the scrotum, depending on whether you are left or right-handed. So whenever you feel the urge to pee, you just press on the button here. Okay, this cuff will basically deflate so that the urine can come out from the bladder to come out. And this balloon here actually contains the liquid that helps to make the whole system run. Okay, so take-home messages. We do know that incontinence is actually very much treatable. There are various methods of very well-tolerated, non-invasive treatment options. The only concern is that some of the oral medications, like anticholinergics, we do have to be careful, because taking them long-term can cause possible cognitive issues. And of course, combination oral medications are definitely helpful to reduce the side effects. Okay, thank you.